I have been involved in Indian health for a long time. I worked for Indian Health until about 7 years ago, at which point I came to the NIH to direct the National Kidney Disease Education Program. But much of what we do in this program is based on what I learned from my colleagues and patients in Indian Health Service. What we're going to talk about is some basic stuff about kidney disease, including how to utilize a lab test for identifying and monitoring CKD and trying to assess the risk for progression based on those laboratory tests, to formulate some kind of strategy for improving outcomes for CKD in the primary care setting, to integrate evidence-based care for patients with CKD into clinical practice, and then talk about some patient education tools, and also talk about referral to nephrology, which is a big issue in Indian healthcare. Just to be sure we're all understanding what CKD is, CKD, the diagnosis, is based on one of two criteria. The first is a functional definition, which is a decrease in kidney function to a GFR less than 60 milliliters per minute, which is about half of normal. And the second criteria is an indication of kidney damage, and that can be almost anything. It can be an x-ray that shows that there's a missing kidney. It can be hematuria. It can be history of a biopsy as a child showing minimal change disease. But in almost all cases, the evidence of kidney damage is albuminuria. And the upper limit of normal for the purposes of diagnosis is generally considered 30 milligrams per gram. And I'll go over that in detail, what that really means. By using those criteria, either a GFR less than 60 milliliters per minute per 1.73 meters squared, or urine albumin greater than 30 milligrams per gram or 30 milligrams per day, about 10% of the U.S. adults may have chronic kidney disease. And if you look at materials from advocacy groups, they usually say do have chronic kidney disease. Well, that's not entirely clear. If you look at this middle column here, for people over 65, that a very high percentage of those people meet those criteria. However, we don't really know what a normal GFR is for an elderly person, and we really don't have a lot of data yet on the rate at which GFR normally declines. So meeting these criteria and making estimates simply based on projecting them on the NHANES population, which is the way this is done, probably overstates the CKD population in the United States. There are lots of people with CKD, and it is a fairly common problem, especially in Indian communities, but it's not probably quite as high as what some advocacy groups promote. What we do know quite firmly is over the last 3 decades, the number of people on dialysis has increased by a factor of 4. Oop, I just oh, okay, and almost over 400,000 people now are on dialysis or have a transplant. Now, the ESRD means on dialysis or with a transplant. It is not synonymous with kidney failure, which is simply a GFR of less than 15. What we're seeing in the United States as a whole is what we've seen in Indian communities since World War II, which is an increase in change in lifestyle followed by an increase in obesity, followed by an increase in diabetes, followed by an increase in diabetic complications. And so what happened with the sort of natural history that we saw in Indian communities beginning after the war, and which led to a real peak in ESRD at the turn of the century, that's 2000, is now occurring in the population as a whole. And you can see that nationally, this curve here is diabetes is the predominant cause of kidney failure in the United States, and that's true in all ethnic groups, including African Americans and Hispanics. The other cause is hypertension, which is major but has leveled off, and the other two significant causes, glomerulonephritis and polycystic kidney disease, are pretty flat. So what's happening in the U.S. population as a whole is an increase in CKD, which is mostly due to diabetes, and in most cases that's type 2 diabetes. In Indian communities in particular, the rates are quite significant, and in the Southwest, where data is collected by what End-Stage Renal Disease Network 15, there are a large number of Indian people on dialysis. This is mostly Arizona and New Mexico. In Arizona alone, there are about 1,366 patients on dialysis at the end of 2011, and there are about 300 new patients. The largest number of patients on dialysis who are identified as American Indian is in Arizona. Arizona and New Mexico together comprise about 40% of all the people identified as Indian by their dialysis units, and probably around 60 to 70% of the Indian people on dialysis who are in the user population for Indian health care. So I think one of the reasons why the diabetes program has devoted an hour to this topic is that there are interventions which will slow the progression of kidney disease, and slowing the progression in one patient for 1 year produces significant savings in addition to reducing suffering and social dislocation. So on average, it costs about $77,000 to have a patient on dialysis. If you figure that the cost of someone who has advanced kidney disease but isn't on dialysis is about $25,000 per year, there's probably a savings of $50,000 a year. So what does that mean? That means if you identify a patient who's at risk of rapid progression and you do something to slow that progression by 1 year, you've not only saved that person significant morbidity, but you've actually saved the healthcare system about 50 grand. So this is a very, very cost-effective intervention.